Awesome. Managing through uncertainty, including technological uncertainty. Great. Well, welcome back, everybody. This is our fifth in a series of sessions about how to lead through the COVID crisis. I am Rosemarie Day. I'm the founder and CEO of Day Health Strategies. And with me today, I have Sarah Matousek and Lara Shadwick. And I will have Sarah introduce Lara when we get to that section of our plan for today. But today's focus is really going to be about how to make decisions in periods of great uncertainty. And I will open by just kind of giving a quick assessment of where I think we are this week. We've provided several frameworks for you to consider. Those are all online at dayhealthstrategies.com. So you can refer back to those. So I'm going to give a kind of assessment based on those frameworks of where I think we are today, and then dive into an overarching framework of how to make decisions through uncertainty. And then we're going to hand it over to Sarah, who will interview Lara about some specific examples of leading through uncertainty and dealing with decisions in those kinds of conditions. And then we'll have time at the end for question and answer as always. So please feel free to type into the chat if you've got questions along the way. We guys always want to be responsive to you and make this something that definitely meets your needs. So in terms of where we are, I actually learned a new term this week, and I think it really aptly describes this rather extreme state. I've been calling this a landscape scale crisis because of the magnitude of it. Apparently, the U.S. military actually, as they have acronyms for so many things, they call this a VUCA situation. That's VUCA. And that means it stands for volatile, uncertain, complex, and ambiguous, which in their parlance, that means it's a really big deal and really hard to deal with. So there are all kinds of strategies to approach dealing with this VUCA kind of situation, but it just underscored for me again kind of the order of magnitude of what we're in. And so I think that means as things continue to unfold, as much as some of us would like to find optimism, we're really also still, I think, experiencing a lot of loss and grief around that loss. And it's very difficult to understand and accept whatever the new normal is going to be. And I find that sometimes it helps to have humor. If we can just go to the next slide. This was one of my favorite slides from a presentation last week. As always, the New Yorker cartoons often sum things up well, but are you talking about the new normal of an hour ago, or is there a new normal right now? So when, as a consultancy that does a lot of advising around change management, and we're usually talking about change that is so much slower and less hard hitting than what we are now experiencing societally right now. It's sort of breathtaking to think about how many things we're asking people to adapt to and how challenging that is. So there's still grief, I think, for lots of folks around this. And yet, as we get through some of this initial surge period, we see what our hospitals are able to handle, what our healthcare professionals are handling, which is really quite phenomenal. And certainly here in the Boston area, we're getting through our surge period and realizing that the worst case scenarios we had been planning for are not going to be, at least at this time, something that we have to endure. And in fact, so we're still, challenged by what's going on, but we're not necessarily going to face what people's, I think, worst nightmares were in terms of what the hospitals would be having to handle. It looks like our system will be able to meet the needs, and that means that the actions we're taking with social distancing and all of the hard things are making a difference. And that, I think, provides some hope that we can respond to this. That said, it's going to be a long road coming. And I have shown that a graphic before about how the stages of crisis evolve, and we have our eyes on how do we get to that ultimate, that recovery. And so another piece I wanted to just give during this overview is that I think recovery, according to the experts that I'm also paying attention to, folks like Juliet Kayyem, who we've pointed you to, former Assistant Secretary of Homeland Security. She's talking about this as being an adaptive recovery. That means we're not just going to come out, and I think as many people are seeing, and just flip a switch and say, all right, everything's back to normal. Until we have adequate testing and treatment, we are going to have to be very flexible in our response, because there could be flare-ups, as we start to ease some of our restrictions and ease back into life and interacting more in person. There will have to be lots of precautions taken. And when there are flare-ups of the virus, we may have to do selective shutdowns. And so it's this notion of being able to move forward, but also always being ready to pivot. And I think as we think about leading through this, having that in mind of how do we continue to manage through uncertainties, and that the certainty is that there will be uncertainty, sort of ironic, but that's the kind of challenge we're facing as we keep moving forward. So today, as I said, I want to talk about how we manage and lead and make decisions through this kind of uncertainty. So let me go to the next slide. We've been using as a framework, and we're getting to the last stage of this, the ways that we would recommend leading in this landscape level crisis. And again, thanks to the McKinsey folks who summed up a lot of great research in an article. And so we've talked about, as a leader, you need to demonstrate empathy and communicate effectively, like all the time. I just heard from the CEO of Boston Children's Hospital, who talked at length about what she's doing as a servant leader to take these exact same steps. We also talked about organizing a network of teams and being really flexible about how you think about leadership and letting leaders emerge in your organization who are able to adapt to this kind of time of crisis and lead from where they are. So today, we're moving into the last stage here, which is the making decisions amidst uncertainty. And I want to go to the next slide, because I'm really just going to base this in a very simple framework that many of you may already be familiar with, because it's what's used during, I'd say, more normal times in terms of looking at ways for organizations to do, process improvement or quality improvement. A lot of healthcare organizations use this, which is why I wanted to ground us in this very simple but very effective framework, and that is plan, do, study, and act, and that's an iterative cycle. So when this framework was developed, it was really meant to address, I'd say, kind of more normal circumstances. And yet, like I say, I think it really can be used during times of crisis. It just has to be used in a more accelerated fashion, and therefore with less time to do what in a normal period you might consider to be full-blown planning. So the planning stage here is really what some have called just taking a pause from getting out of like the hecticness of crisis management, and kind of taking a deep breath as a leader and gathering the information from your network of teams and those people who are on the front lines. And one of the ways that you can do that that has been used effectively in a number of organizations is through a huddle. If you have a small organization, you can have a daily huddle for 10 or 15 minutes with your core team. If you have a bigger organization, you can use the idea of tiered huddles. So you have the frontline workers huddling first, and then somebody's conveying to the next level within the organization the things that came out of that frontline huddle and moving that right on up to the senior executive leaders. Or you can use that with your network of team structure. But gathering that information rapidly and synthesizing it and making a plan in a relatively quick time frame, that's the plan stage. So not time for full-blown studies, all of that. It's just doing the best you can, accepting that level of uncertainty, but you getting the information you can and using it so that you can then do the next action. And the idea here is that you're going to try something, and it may not be the perfect thing, and it may be the thing that's right for now but won't be right for next week. This is, again, we don't know, or it might be right for the period of initially coming out of this COVID crisis, when we come out and start to reemerge and reestablish some normal parts of business, but maybe, again, we'll have to pivot. And so the idea here of doing is to carry something out, but know that you're also going to be continuing to gather the information as to how that's working. And so the study doesn't mean like a 2-year study. Again, we're talking very rapid cycles here, but that you will gather from your teams the information, as best you can with the nodes and feelers you can have out there, what is working, what's not working. So if you're trying to figure out in the new normal, what do your customers feel comfortable doing? You know, maybe they're allowed to come out of their houses and some stores can open, or doctors' offices can reopen. But are people going to want to go in the way that they used to? Most likely not. And so how is it that you test what people's willingness is to engage in some telehealth or, Zoom fashion versus in person, or some combination thereof, and start to gauge people's comfort level with different approaches. And then again, you're iterating. So you gather that information and you'll know how people are feeling for that week or maybe that month. That could change again in another month, depending on whether new treatments have come out or we have better information about the virus. And so perhaps, things can ease up even a little more. But the idea is this study is you're gathering information again from that network of teams and then bringing that back in so that you can iterate with that information and act on the results. So it's the same kind of framework that you would do if you had in the fullness of time to study something as you might really want to, but you have to do it rapidly. And so I think it's helpful to just, not try to reinvent the wheel here, but just basically say, take this best practice and use it in this more rapid cycle kind of fashion. It takes some humility. Again, we've used that theme before. As professionals, we are used to knowing the answers. We feel sometimes like we're supposed to know the answers. And really, in this situation, there is no playbook. So we do have to try things and we have to be able to pivot. So that's my introductory overview. And I want to hand it over to Sarah, who can introduce Lara to give you some examples of how this has been put into action in other.
Great. Okay, so can you hear me?
Yes, we can.
Awesome. All right, I'm gonna begin by introducing Lara to everyone who hasn't met her before. So Lara joined us as an affiliate consultant last November. And prior to joining our firm, she was the program director at Matousek Quality Health, where she developed a successful complex care program to address high-need, high-cost patients in a rural setting, importantly. And she'll be discussing a little bit more about that in detail today. As a senior consultant, she expands our expertise in community engagement, rural health, telehealth, community health worker programming, population health, that sort of thing. She also has a lot of experience building community-based coalitions. And she's also developed programs in conjunction with several different alternative payment models. And in addition to these areas, Lara's also served as a health system marketing and PR director and as a community behavioral health executive. So lots of different experience to draw on. Lara holds an undergrad degree and an MBA from the University of Colorado, and she currently lives in Colorado Springs with her 2 children. So without further ado, Lara, we'd love to talk to you today about decision-making and uncertainty, as Rosemarie has already discussed a little bit. So clearly, as we all know, there is no playbook for the pandemic. And you and I have spoken many times about your previous experience building that rural complex care program in Montana. So could you just start by telling us a little bit about the work that you did there?
Sure, thank you, and thank you for the opportunity to speak to you today. So in Montana, we started this program at the end of about 2014, beginning of 2015. And there I was building healthcare coalitions in a variety of rural locations in Montana. And by that, we were bringing many stakeholders together, often that had competing objectives and agendas, and trying to get them to work on reducing readmissions and working with vulnerable patients. So the one thing we could get everyone to agree on, which is a hard thing to do when you have a variety of opinions and stakeholders, is to work with high needs, high cost patients. They affected everyone. And we ended up looking at what was out there and developing ultimately something that was brand new. And we started with, looking at urban models and started looking at what was in the literature and talking to experts, and then coming to the conclusion across the communities in the whole state of Montana that we had to develop something novel. And so there was no playbook to take off the shelf. We actually had a nurse that was like, well, where's my binder? Where do I get my binder? And there was no binder. I'm like, well, we're going to make one. And we're going to learn through this together. So that was kind of an exciting time. And, actually it turned into be a really great opportunity because we created excitement around something new, something novel, something that we owned, and something that, own in like creating it and putting it together. So I would say that was the beginning of it.
That's really fun. Okay, great. So since we're in the decision-making consideration today, how are you able to make decisions really without anything to go on? You already mentioned that you did look at the literature and you did use urban models, but what was your decision-making process like?
So there was a couple things that played into it. One was for me personally, I had taken care of my father remotely. He had multiple chronic conditions. He had worked himself into a place where he had social determinants of health going on everywhere, and the problem of trying to manage what was going on in his life and his medical things, and they were just so complex. So I had that history to draw on, and I was taking care of him from Montana while he was in Colorado, and learned how to work with providers remotely and to manage things and really see what wasn't working in the system. So I had that personal piece. But then we also built a feedback mechanism where we would look at data once we started collecting the information, and then we would adjust based on what we learned. An example would be we were building a community health worker program. There hadn't been really many in the state, and we didn't know what to go on. And we learned through the process, it was kind of an aha moment, like, okay, we need a different level of community health worker than the one we started with. And so we just modified based on what we learned. Another thing that was kind of fun that we, to speak about now is we started Zoom meetings 5 years ago, actually six or 7 years ago now, in little rural Montana. And the reason was that our communities were isolated by geographic distance. It was more than 100 miles between these different communities, and we had to go to Zoom meetings in order to be able to bring everyone together and create a learning environment. So it's kind of fun. We had these monthly patient case, de-identified patient case conferences that we would Zoom in, and it was not only creating a learning environment, but it was also creating a supportive environment, because it was stressful to the teams to try and create something new. And so we could share something that we learned in one community that may help another community, and we could also look for resources and then look for support, because working with this patient population could be emotionally challenging. And so it was creating support for the different individuals and the teams and bridging distance through technology. Incidentally, part of the program that we built used telehealth also. We brought iPads in to bridge distance. And so, being able to learn this in a novel way and taking that in a rural setting was unique into itself. So we would just kind of learn and adjust and bring in new team members and experts. And then we always kept the end goal in mind, which the end goal was to build something that was sustainable. So, and then we would identify training as we needed. So one thing that we ended up needing was like motivational interviewing. So we went and got training on motivational interviewing as all the collective organizations.
That's great. So we've talked before about, things that you used to make those decisions as you went along as a leader. How did you adjust as things went wrong, as an example?
I think one of the great things was we really spent a lot of time making this a learning environment. Mm-hmm. And we I personally wanted to set up an environment where it was okay to make mistakes. And like Rosemarie was saying, we're all professionals. We're all like trying to achieve the best thing that we can. And it's hard to back off and say, okay, I'm really struggling with this part, or, this really didn't go well. And, being able to ask peers and experts on our monthly calls what to do and how they seek help. And so being able to create that environment where it was okay to make mistakes, I think really helped us make leaps and bounds and really go to an innovation faster and go through the cycle where we can, act, change, adjust, and then, promote that trajectory. The other thing I would say is that we created an advisory council that had a bunch of different experts on it, everything from payers to educators to people that were rural, people that were more urban, and we created that whole conglomeration of people that could provide input. And so it wasn't up to just the teams to make the decisions. They could get informed decisions. They could collaborate. And so really building a collaborative environment was important. And part of that was picking the right personalities, ones that were okay with not having the binder off the shelf, okay with being able to go into uncharted territories and explore and make mistakes and talk about it and build, and always keeping the patient at the end goal and not just the agendas that come with everyone that they bring to the table.
That's excellent. And I love how it dovetails with what Rosemarie was saying. In fact, Rosemarie, I'd love to hear your any additional comments that you might have where Lara's stories, either, that she just mentioned now or that we've talked about previously with her, dovetail with some of the things that you've learned in decision-making amid, uncertainty, or, even some things that are certain, but, that can relate to what we're dealing with right now.
Yeah, I think it jives so much with some of the experiences I've had where when you're doing something for the very first time that no one's ever done before, and that was certainly true when we launched the first health insurance exchange in Massachusetts and under rapid fire conditions. No one had done it, and there was no playbook, and so we had to have people who had solid experience, but it was in their respective areas, but no one person knew everything. And so we had to figure out those ways to work collectively and make it okay to make mistakes. That was a really important point I think you made, Lara. It's hard when you've got, as I said, professionals who think, oh, I'm always supposed to have the answer, especially if you feel like you're in the spotlight. It's really tough. And so we talked about being a learning organization, and we would say we're going to do the best we can, but we're going to learn from what we've done. We basically were following that cycle of the plan, do, study, act, and so that's how we survived. And I think it's a really good way to think about moving forward.
Yeah, I can imagine the no playbook scenario rings true in a lot of the collective experience that you all bring to the table. So we're in it right now. Lara, I do have one last question for you, which is, and I'd love to hear your take on this one as well, Rosemarie, if we have the time. What was your biggest leadership takeaway from that experience, in rural health, and how do you think we can apply that to our current situation in this pandemic and crisis?
Yeah, I think really when you look at the lens and you look at it through uncertainty, that you know, in my kind of background of building coalitions, even in rural and urban settings and a variety of different things, everyone comes to a problem, a situation, a project with their own agenda and their own needs and their own desires to drive things certain directions. And at the end of the day, you as a leader know in your gut and in your heart what is right for the patient, and you have to lead from that internal compass of what you know is right, and make the decision to move forward, even though it's not going to make everyone happy all the time, but that you're always moving towards what is the end goal of the patient and of the goal of your program. And I think that was probably the, you know, I guess kind of a milestone in my development as a leadership, is just to be able to tune out the noise and look internally and say, okay, what is really the right thing to do? And you have to move that in direction and bring the people with you.
Yeah, I would just, I would echo that and then add to it and just say, helping everybody keep that clear sense of purpose. So when you have people coming together with those different agendas, perspectives, you know, all the differences that come together in a team, if you can stay really focused and as a leader, just keep communicating about that problem you're trying to solve and keep people rallied toward that, you can cut through some of that other noise. And I think sometimes that's easier when there's a crisis because it's just so obvious what the purpose needs to be. But I think that's really important aspect of leadership.
Absolutely.
So thank you.
Yep. Thank you, Lara.
So we want to thank you, Lara, very much. We want to basically wrap up today's session, leaving you with another quote to contemplate. So we'll go back over to the slides for a moment. This is something that Rahm Emanuel said, which he paraphrased. We did a little research that actually this notion stems all the way back probably to Machiavelli. But Rahm Emanuel famously said this during 2009 when he became President Obama's chief of staff, and they were tasked with trying to grapple with what became the Great Recession that started in 2008. So he said, "You never let a serious crisis go to waste." And what he means by that is that a crisis presents an opportunity to do some things you think you could not do before. And so as we try to start to imagine a future and look for the silver linings of what this really challenging time is bringing, what are some of the things that we could do that make permanent changes for the better, whether it's you know, in your business life, in how we approach healthcare, and how we address some long-standing issues that haven't been addressed. Can we use this crisis and not let it go to waste? So I'll leave you with that. We will be back next week for another session about leading through uncertainty. So thank you very much for joining us. Again, the sessions are on our website. You can reach out to any of us with follow-up questions at any point, and we wish you well during the coming week. Thanks again. Bye-bye.
Thank you.